Hello, everyone, and welcome to the Caresify Spotlight series, part of Caresify Health Talks, where we shine a light on caregiving, community, health, and the stories that impact families every day. I'm your host, Angel Bell, CDP and Director at Caresify Home Care. Today, we're talking about something that affects millions of families: dementia and Alzheimer's. These two words are often used interchangeably, but they're not the same. And understanding the difference can make a world of difference when it comes to care, support, and planning. I'm honored today to welcome a leading expert in this field, Dr. Domenico Praticò, North Star Foundation Chair in Alzheimer's Research and Professor of Neurosciences at Temple University. Dr. Praticò, thank you so much for joining us today.
Hello, and thank you for the kind invitation to be part of this health talks. I'm truly excited and honored to contribute and to discuss about some of the topics that you just mentioned, topics that are so important that interest and involve a growing number of people, patients, family in this country and around the world. Topics that have been the core of the mission of my entire academic career for the last 25 years. So I'm truly looking forward to our conversation.
Thank you again so much. Our goal today is to help families understand what dementia really is, what Alzheimer's is, and why the distinction matters for care. We'll talk about early warning signs, how to navigate conversations with doctors, and common myths that can get in the way of getting help. Let's start at the beginning. So many families begin noticing small changes, maybe mom forgetting appointments, dad repeats the same question, or a loved one gets confused about the day. But they're not sure if this is just normal aging or something more. Dr. Praticò, what are some of the earliest signs families should be paying attention to?
Yeah, this is an important point. I'm so glad that we start the conversation really from the beginning. And it's true. It's true. Many of us have this moment in our life, and we notice some changes. And this, most of the time, can trigger a lot of stress, a lot of anxiety. And it's pretty normal when we see our loved one, our father, our grandfather, who is not, would say, the same person as before, is forgetting things, is not doing things properly. But I just want to really clarify because this moment, if they're just moment, can be something that can happen to anybody. So it is normal in a way that with age, getting old, we cannot perform the way we would perform 20 years later. In other words, somebody who is 75 obviously will have some type of performance that is not identical to somebody who is 55. So this is important. So although we may pay attention to these changes, is there are a general concept I would like to really be clear about it for our audience. First of all, whatever sign I will be talking about has to be signs that are present on a kind of consistent manner. What I mean by that, something that does not happen randomly here and there, something that happen, for example, once a week, twice a week, or three times a week. And another important aspect of those signs is that they are so important that kind of disrupt the normal routine of that individual. And so among the signs, obviously, the first things that we may notice is something related to memory. And memory can be different type of memory. We can have a short-term memory, for example, could be related to something we did in the morning, and then in the afternoon we try to remember. Or we have memory, so-called long-term memory, which refers to things that happened a year ago, 10 years ago. Typically, one of the signs that could be related to some type of cognitive decline or Alzheimer is problem with recent memory. So in other words, something that has to do with episode, action, a moment that happened in the morning, the day before. So when these things happen, that could be not remembering the name or the place where we were, and that happened on a certain frequency, that could be something sign of concern. Beside the memory, sometimes can happen that the person, for example, keep asking the same question once again, like, where are we going? Where are we going? So we give the answer, but it looks like the individual, unfortunately, did not really capture the meaning. Beside memory, obviously, we can have, for example, things has to do with ability to accomplish tasks, familiar tasks. Let's imagine cooking. Cooking is something that, our mother, our grandmother, whoever is this loved one, something that she or he would do in a heartbeat. Now we notice that, for example, even the process of cooking, which means put together ingredient, is a challenge. And so the individual maybe does not remember exactly whether there was need of garlic, celery, or whatever. Or another things in the task, the ability to accomplish a task could be related, for example, to getting dressed in the morning. Again, this is a task that normally a normal individual would do in a heartbeat, would be spontaneous. But now suddenly, even button up a shirt could be a challenge. And another sign that we need to pay attention is the confusion of the individual with time and place. Where are we? That's the classical question. Although we are in a very familiar place, whether it's church, whether it's market, there is this question, this kind of confusion of the place and the time, whether it's morning or afternoon. Another example related to this is the problem that the person, for example, can have in accomplishing a routine task related to place and time, like driving from home to church, from home to the supermarket, that suddenly became complicated. So this typically are the three most frequent. There are others, obviously, and I just want to mention quickly. There could be problem, for example, with judgment, problem with tasks, like, for example, doing things that before they were spontaneously okay, but suddenly there is a mismanaging of a situation. And finally, what can happen, although it's kind of rare, we can have also conditioning in which there is a change in personality and a tendency of, for example, an individual who was very open and social, suddenly kind of there is a withdrawal of this individual. The individual tends to isolate himself or herself. So this a little bit the sign and symptoms we should pay attention. And as I said, although they may create anxiety in everybody, family and friends for our loved one, they should not be considered as a source of stress, because what we need to do is, first of all, to pay attention whether or not how recurrent they are. And the other question we need to ask ourselves, is this change impairing the regular daily life of our loved one? And that's, I guess, the most important aspect. We need to pay attention. But any sign, as a regular rule of thumb, is important that we that live with this person pay attention to.
Yes, this is really great information, and that's exactly what I see with many caregivers. There's fear, uncertainty, sometimes even guilt. Families want to believe it's just getting older, but those early signs can be the best opportunity to get answers and support. One of the biggest barriers to early diagnosis is stigma. People are afraid of what it might mean, so they avoid talking about it. But starting the conversation, if you start it early, it gives families more options, from medical treatments to community resources, care planning. Given your expertise, can you share some insight on that?
Yes, yes. Stigma, it's a big problem of Alzheimer's disease, of a condition characterized by reduction of the cognitive ability, memory, ability to complete a task, to learn new things. There's no doubt that in the last 20 years, things have changed, but there is still a lot of work that we need to do. And this comes from what I just was talking a second ago. We go through phases in a way as people directly involved in this condition, in the situation, because our loved one now suddenly has something that is impairing her or his ability to be like the rest of us. The stress, it's basically little by little became fear, fear of the unknown. But sometimes it's also fear of what other people may think about it. So that is something that in the last 10 years I've been really adamant, try to really be a person who try to convince that there is nothing to be ashamed. There's nothing to hide. And if you allow me, I just want to make a little comparison. What I see today with Alzheimer's disease is what in the 70s and the 80s people were experiencing with cancer. As we know, another horrible disease. But in the 70s, in the 80s, people who had cancer, they would withdraw from society. It was almost a mark of you are not like us. You need to stay away. There was all this concept of really negative about the disease, about the individual who had the disease, which was the wrongest possible approach. So again, in this case, and nowadays totally the opposite. People fight for cancer. People stand up to cancer. Still, I don't see anybody or few people say, I'm going to fight Alzheimer's disease. I'm going to stand up for Alzheimer's disease. This should be a change, a shift in our way. So I'm really here talking to you as a caregiver, you as a son, as a daughter. If our mother, our father has indeed Alzheimer or there are this situation, there's no reason to be shy or concerned or ashamed. We need to really think about a disease like a disease because ultimately this is not a death sentence. Facing the disease in the earliest possible stage is the best things we can do for the patient and for ourselves because it will give us better option. After all, knowledge is power. They give a power to us to really look for what could be the best approach, the best preventative approach or therapeutic approach. And we talk maybe later, there are a lot of situations in which actually we can reverse completely the condition. And this ashamed, this shy, this not talking, I just want to mention quickly another important aspect that I heard many times from family who ask this question. Can I say to my child that grandpa has dementia, has Alzheimer's disease, or should I not say anything? So this is a very important topic, whether or not we should talk with children about this disease that is affecting us as a family. My short answer is always yes. Yes and yes, we must talk. We must tell the truth to the grandson or granddaughter. And sometimes we want to protect them because what we think is it's stressful for us as an adult. That could be a source of stress for my child. Why do I want that? Well, I think it's in the long term, the best approach is to explain that granddad or grandmom has a problem, has a disease that is impacting her memory and not dismissing, say, oh, don't worry, it's just because he's old. Because actually that sometimes can trigger extra stress because the child then can kind of think about it, say, well, if he's old, he has now memory impairment, that would be your case, dad. When you get old, you will be also like grandpa. And so that's, I think, is another important aspect in terms of stigma and fear that sometimes kind of take control of our actions. So the message here for really everybody, me included, is we must talk about it. We must face it. We must not be shy or afraid and of course ashamed of something that today, particularly today, we have so many tools available that would allow us to really navigate the system in the best possible way.
Sounds like you're doing wonderful things with your research, and it also sounds like we're going to need a lot more advocacy groups to get out there and really just, dive into the population and educate them. Early conversations aren't just about the diagnosis. They're about preserving dignity and improving the quality of life. I always tell families, trust your instincts. If something feels off, it's okay to speak up.
Yeah, absolutely. I think again, it's the concept of being aware with caution. Again, try to not jump to conclusion, first of all, about a clinical condition. So once we know, if we notice that those signs are present with a certain frequency, are really disrupting the life of our loved one, it's the most natural things to really take action. So take action because the individual per se, our loved one, most of the time also will be in a state kind of denial because it's human nature trying to compensate our deficit, try to come up with this mechanism that in some way kind of compensate and correct. And the usual nature is, oh, everything's going to be better tomorrow morning. It's like a bad dream. So this, it's very, it's understandable. I totally get it. I understand. We're part of what we are. But in this case, there is no doubt that today awareness and the same time action is the best possible thing we can do. And as I said, it's important that we try to involve the loved one also. When we talk about action, I'm not thinking just we independently start calling doctor or going around, but really try to be as close as possible to our loved one and try to understand as much as possible what is the situation. And that obviously is going to lead us to some type of clinical scenario where really we can have answer that are very specific on whether or not our loved one is indeed developing some type of cognitive decline. So absolutely speak up and spreading and awareness is super important. And going back for a moment, as I just said before, up to recently, we found out about famous people having the disease only after they're dead. Let's think about President Ronald Reagan. Let's think about Gene Wilder, a famous actor, Pat Summitt. All these a few names. And what happened is that they probably had the power to speak up and share their condition, which, as you know, is the opposite of what happened for Parkinson's disease. We have Michael J. Fox, who has been brave and really fearless when 20 years ago he announced to everybody, I have Parkinson's disease. He wasn't ashamed. He wasn't afraid. He just
Yes,
said the
wonderful.
truth. So this is what in this field should happen. People who have this public power of should speak up and be the spokesperson. So that's what I'm trying to do in my last 10 years. I'm trying to convince really that we should not be ashamed. We should be proud because nowadays also there's a lot of option we have. Therefore, absolutely, knowledge is power, awareness is power, and because this is a battle that we together is going to fight. There is no one is going to win this battle alone. And we are not alone. Nobody's alone. I'm just talking to you as a caregiver, you as a family. You are not alone. There are so many people in the same situation, and that it should be a source of strength, psychological strength, to really face this with dignity.
I agree 100%. Because one of the biggest points of confusion I hear is when people say, my loved one has dementia or my loved one has Alzheimer's, like they're the same thing, but they're not. Dr. Pratico, can you help clear this up for us?
Yeah, it's a very timely, a hot topic. Still today, there's a lot of confusion, and I don't want to use the word misinformation, that it's a kind of trendy word, but there's confusion, and it's confusion because there is a history behind that. This is a disease. Most of the time, people ask me, is Alzheimer disease or dementia something that related to the modern time? It's because we use cell phone. It's because the industrial revolution. I answer say, no, there is no evidence. Dementia or Alzheimer's disease is a disease that we had for centuries, if not thousands of years. There was no such a concept. Already it's only in 1906 for the first time that we have the description of the first clinical case of Alzheimer, which we call then Alzheimer. There was a German doctor who had a patient, a woman, 51 years old woman, who was brought to the hospital because she started to behave in a way that people thought she was crazy at that time, 1906. She wouldn't recognize the husband, the children, and started to have all this behavior. So we're brought to the hospital. And the story is she never left the hospital because the situation get worse. And so Dr. Alois Alzheimer, a German physician, wrote this book, this chapter, this article, and published it. And he called the disease as a peculiar disease of the brain. And it described exactly what today think about Alzheimer's disease. But what happened here, that's what I said, there is a history behind the confusion between dementia and Alzheimer, because that was 1906, 1908. But up to 1990, no one used the word Alzheimer's disease. I was in medical school. During my round, we had an individual, an old lady who was 80 something, and she had obviously dementia or Alzheimer. And at that time, the attending would not use the word Alzheimer, would say, well, she's just senile. This is senile. It's okay. When you're old, you forget. And so I remember the frustration as a young doctor because I knew that the next room, there was another 81 years old lady who was sharp like a tack. So she had all the memory. And so what I think I thought, why two individuals, same gender, same age, one really has no memory left. The other has all the memory. So we cannot say it's just senile. So that's where the concepts start to blur between dementia and Alzheimer. So going back to the question, dementia is a term that describes a clinical situation. So it's a symptoms. Let's say it's like somebody who has a fever or a cough or any other sign, which is just a signal of a real disease. So the word dementia should not be used when we want to say that my father or my grandfather has dementia, because it's a very general terminology. And under the word dementia, because it's a symptoms, we can find different diseases. Now, the confusion sometimes is because the most frequent cause of dementia is indeed Alzheimer's disease. So just to clarify, Alzheimer is a form of dementia, but dementia is not Alzheimer. So I hope this is clear, because anytime we heard the word dementia, we should ask if we in a conversation, but what type of dementia? Because nowadays, each type of dementia has a different diagnostic process, has a different therapeutic process. The approach is totally different. So 20 years ago, it was okay. I think today, 2025, we need to be very careful. As I said, Alzheimer's is the most frequent. It's about 60%, 65%. Let's imagine we have 10 people, 6 of them who have dementia as a symptomatology, who have problem with memory, they will have Alzheimer's disease. However, we have 3 or 4 in the same room who have still the memory problem, the cognition problem, have the symptoms of dementia, but they're not Alzheimer. So the other type of dementia that could be identified diagnostically, for example, it's vascular dementia. Vascular dementia is about 15%, 17% of cases. And vascular dementia, it's similar, but it's also different. And I'll try to really explain the major difference. Alzheimer's dementia is characterized because in the brain there is a deposition, an accumulation of toxic protein substance like the amyloid plaques, or the tangle, which is another protein. This form those deposits that are very dangerous and toxic for the nerve cell. So they kill the nerve cell in a specific area of the brain that is important for memory language, such as hippocampus or amygdala, and so forth and so on. By contrast, vascular dementia has not such a thing. We don't see in the brain of an individual with vascular dementia the deposit of the amyloid of the tau. Vascular dementia, as the word tells us, has to do with the blood, with the vasculature. The vasculature at the vessel that brings blood to the brain. And so in a situation which we have, for example, a thickening of the wall, or the wall is a little less open than usual because there is an obstruction, less blood will reach the brain. And so if this amount of blood does not satisfy the need of oxygen and nutrient, the cell that depend on that vessel is going to die. And so the vascular dementia, it's a situation where the damage is more diffuse, and we have simply the cell that start to die, but die not because there are toxic plaques, dies because there's not enough nutrient. And so this is another type of dementia. And I'm going to mention the third one, which is again could involve about 7%, 8%, is the Lewy body dementia. It's a very less understood type of dementia. It's a type of dementia that in this particular case has to do with a protein completely different from the amyloid or the tau. There is a protein we call alpha-synuclein, which kills and precipitate in particular area of the brain. And this is basically correlated to what do we have also the frontotemporal dementia. Just to really make this clear, is the disease that recently the actor Bruce Willis said to have, the frontotemporal dementia. Again, it's a dementia, but it's not Alzheimer. And this, for example, symptomatology, although there is memory problem, this form of dementia and manifests most of the time with personality change, behavioral change. So these are things that really are important to keep in mind. And really it's my hope that this confusion between the word dementia and Alzheimer gets really clarified. So to recap, dementia, it's a symptoms. It's a manifestation of a disease. Alzheimer is a disease, Alzheimer disease.
Thank you. That's so important for our audience to understand. And also, I really appreciate you describing other types of dementia and going into what they look like and so on, because that is so important for this audience to understand. We all need that education. I know I do as well. And this is where families often feel confused. Um, the symptoms can overlap.
Yeah.
And having the right diagnosis probably can help families plan better, prepare for what's ahead, and connect for the right support systems. Can you dive in a
Yeah.
little more into that?
Yeah. It's important. It's very important because we know that we have different type of dementia, and so that's where we go back to what we were talking before: is the being proactive. It's to really face the situation without delay. That's important. I really hope that this message gets clear. There is no reason to delay any of these steps that need to be taken. And so again, the fact that our loved one start to have manifestation, which described before, I will not repeat here, that are really are alarming to us, are a source of concern, is the time where we need to really be proactive. But being proactive because nowadays, with this information and the tool we have available, it's a situation where there is a lot of things we can do for our loved one. And the wrongest possible things is to delay or postpone. Oh, let's see what happens next month or next week. Maybe things are going to get better. Unfortunately, most of the time, things don't get better. Things slowly but certainly keep going. What I also to stress here, which I didn't say before, we know today that when the first sign appear, the sign we talk about short-term memory or completing a task, the disease has been there for a couple of years. There are studies showing that the disease start 2, 3, up to 4 years before the clinical sign manifest. And that's, I hope, it's real and a stimulus for everybody, for myself, for the family, for the caregiver, really an extra reason why we should be proactive, because it's a moment where we can really have a help. And the earlier diagnosis means an early type of approach that could be aimed, for example, at slowing down the process or correcting the process. And I just want to mention here very, very, very quickly that one thing that most of the time family don't pay attention. There is about 10 to 20% of case of reversible dementia. It sounds crazy. It may sound crazy, but here's the story. Anytime we have the sign that we described before, are concern to us, stressful to us, if we take action, we go to the doctor, to the specialist, one of the first things that the specialist is going to do is to, after confirming that indeed there is a cognitive decline, indeed there is what the symptom of dementia, one of the things we must do is to exclude situation that could justify that dementia. It can be corrected. I'll give you three examples for the audience. One, for example, people sometimes don't pay attention that a deficiency of some important vitamins, such as B6, vitamin B12, and folate acid, they are three important vitamins for our brain health. Our brain works thanks to those vitamins beside oxygen and sugar. So if we have our loved one who, for whatever reason, the diet is not the best possible on earth, is not taking the fruit and vegetable that has the vitamin. Remember, vitamin is something we cannot build ourselves. We need to take from outside. Therefore, we have a condition in which a deficit of vitamin B6 and B12 can be tested with a blood test, a simple blood test. If that's the case, if you give back the vitamin, dementia is gone. That's an example of reversible dementia. Another example very often happen that the thyroid gland, which is a gland everybody has, produce important hormones for our energy, our body, our building and growth. Sometime with age, the thyroid gland starts to work a little less. Therefore, the product of the thyroid gland, the thyroid hormones, the level, instead of being normal, start to go down. And once again, low level of thyroid hormones can influence our cognitive ability, our memory, our ability to do tasks. Once again, with a blood test, any doctor can check the vitamin B6 and 12, the level of the thyroid hormone, and also the level of the red blood cells. A condition of low red blood cells, such we call anemia, per se, could explain dementia. So these are three clinical conditions in which we can completely reverse and correct. So that is an actual reason why you and I should be proactive the moment we think there is something like a dementia condition, because there is this 10-20%, it can be corrected immediately. Why would I not do that? So this is a very important topic that I hope resonate with family, resonate with caregiver. Again, an extra reason why not to be afraid, ashamed of a clinical condition that our loved one is experiencing.
That's a lot of great information, and I'm learning so much. I really appreciate that. Things that I need to think about too. Let's talk about the next step. When families decide to bring their concerns to a doctor, it can feel overwhelming. What is your advice how to get them clear, help, and useful answers?
Yeah, it's my advice is again, go there, go to the doctor. Of course, do not postpone, as we said a second ago, being proactive. Go to the doctor, the specialist, whatever we decide to go to take our loved one, and be there with an open mind and ask all the questions that can pass through our mind. There is not a question that is a silly one. Shouldn't be afraid to ask anything. Really be an open book. Because in the particular case, sometime our loved one maybe is not really cooperating a lot. Sometimes there's this kind of intrinsic psychological reaction. So we should not leave the moment of the doctor visit as a tribunal, a trial. I'm going to be judged. Nobody's going to judge anybody. We need to be there and be open and be ready to have this conversation. But at the same time, be aware, as I mentioned a moment ago, that the scenario could be so heterogeneous, so different, depending on the situation. But definitely, this moment of recognition of a real problem. It's a moment where really we're going to have the power to make a decision that would be important that will affect the rest of the next 7, 8, 10 years of the life of our loved one. So it's a moment where we need to be prepared and really follow the advice that we're given. And so the fact that the doctor, again, wants us or wants our loved one to do certain tests versus other, it's something we should not be afraid. Again, being this fear of knowing something would be not the best approach. And what I want to say here, I touch quickly upon, is that sometimes we can make the mistake of saying, well, nowadays I can go online and do my self-assessment of my memory, of my loved one memory. This is the biggest mistake that we can possibly do. Because I understand you can do your test in your private room, nobody's going to check on you, and so forth and so on. But this is just something that is not my advice. Because doing that, it open up a really long list of other issue from false negative result. By false positive, you do a test and the test says, yes, you do have the disease, but you don't, and so forth and so on. But it's a situation where what we need to remember, and that's, I hope really I'm clear in that the diagnosis of Alzheimer's disease cannot be done just by a single visit to a doctor. It's a complex process. It's a complex journey in a way, but that should not deter ourselves from doing it because it's going to be a series of medical examination, medical tests, and a lot of imaging test technology implicate. That's an extra reason why those self-assessment are not the right things to do. Absolutely. So going to the doctor, the feeling overwhelming should be compensated by the fact that we are now in the process of knowing the truth. So that sense of stress, that was this big question mark, this kind of situation of unknown, now should give us full knowledge. And as I said previously, knowledge, it's power of making decision. In this case, would be the best possible decision to really navigate this journey, a journey that is going to be most likely a long one. And for really the good of our loved one, for ourselves, is the best thing we can possibly do.
This is wonderful information, sounding like approaching it from a unity standpoint and really going to professionally get the help you need and speaking to the doctors. I feel like that's something that can really help you in the long run and help everybody cope. And again, like you said, it's work on this together because there might be some times that it can be reversed. I mean, from what I heard you say, this is happening a few years ahead of time. So that's, if you're starting to notice things, there's possible reversal opportunities there. And that's just amazing. Thank you. Another myth I hear is that dementia only happens to older people, but early onset cases do exist, and ignoring symptoms can delay care. Can you talk more about this and possible options for these early detections more in depth?
Yes, when we think about dementia, we think typically an individual who is older than 65, 70, 75, and this is what we call the classical late onset dementia. If we think about again a group of patient, 100 patient, 95 about of this patient will have this late onset dementia, which is the most frequent. However, as you properly alluded to, there is a small percentage of cases that where the cognitive decline, this cognitive impairment of dementia, the symptoms appear when the individual is in the 40, in the 50, which is very rare. It's about typically 5% of the cases. And what we know in the classical early onset of dementia is that in most cases, in the majority of the cases, it's secondary to genetic mutation. When we think about genetic mutation, we think about the material that we inherit from our parents. Is the DNA, this important component inside each cell that is a kind of the master regulator of the things each cells need to produce. And so if we have a gene, a piece of DNA, which is different from the normal, whatever is the product will be abnormal. So these are cases in which the offspring of an individual with a mutation has this altered DNA, therefore the amount of, in this particular case, we know the amyloid beta it's produced, it's abnormally elevated. And so this basically by the age of 30, 35, 40, have basically the brain which is totally engulfed with the amyloid beta. And the brain basically cannot handle it anymore as cells start to die. And so we have the classical memory impairment symptomatology of the full dementia. But what I want to talk a little bit is some new cases that we are now seeing in young onset of dementia, which are not related to this mutation of the gene. So the DNA of this individual with young dementia, early onset dementia, it's perfectly normal. It's like mine and yours. However, what we are noticing that there is now an increasing number of individuals in their 40, in their 50, who really manifest the full-blown symptomatology of dementia, from the memory impairment to difficulty to complete a task, so forth and so on. And these are really troubling because, as I said, there's a lot of work we're trying to understand from this type of non-genetic early onset dementia. And the work has been done so far has been really very exciting because we are now trying to really dissect what could be responsible, why an individual in their 40, in their 50 develop this symptomatology. And the short answer is that clinical studies have shown that today, thanks to the new technology, that's another important aspect. We can make this diagnosis. Most likely in the past that was difficult, but what we know that there are a lot of so we call risk factor. A risk factor, it's a condition that put an individual at a higher percentage to develop, a risk to develop the disease. Is not a cause of disease, but it's a higher probability. And so we know, for example, that individuals who have type 2 diabetes who is not well controlled, when we think of that, is the level of glucose in the blood, or high blood pressure not well controlled medically, these are conditions that indeed nowadays are responsible for the damage we see also at the brain. And this is a very new concept because a few years ago, no one would ever think that something in the periphery, such as diabetes, high blood pressure, can influence also brain health. But besides those two important metabolic factors, which as you can see can be corrected easily, that's going back to the question, if there is a case of early young onset dementia, the options there are really readily available. We can do a lot. In this particular case, fixing the glucose level, fixing the high blood pressure. But there is a new risk factor for early onset dementia that I would like to spend a few words about it. And what is known, and we found that the other important risk factor is social isolation. When I think about social isolation, I think about today. We most likely are all using all these platforms, social platforms, Instagram, Facebook, so forth and so on, which are all wonderful tools. But what's the other side of this coin is that they typically, in most cases, tend to isolate an individual. The individual is going to be interacting just with a screen. Is the text message versus a conversation. It's using this tool, which is wonderful, and really helps to bring down barrier distances. But at the same time, the risk is that depending on this tool just to socialize, to interact with other humans could have a long-term effect in our brain health. And so social isolation has been now recognized that by the World Health Organization as the next strongest risk factor that can have negative effect on brain health. So this and the message here, I hope it's clear for anybody that early onset dementia is not just anymore a genetic problem, which we can identify, we can know and predict. But early onset dementia or young onset dementia is now a social problem because the major difference here is the following. Think that, again, when we think about Alzheimer's disease, we think about a grandparent. Now it's a parent who has dementia. Is somebody who has children, they may be 10, 12 years old. It's not a situation. So from a social, economical point of view, the consequences are really enormous and unpredictable. So the message here is this is a risk factor that can be easily corrected, fixed. So we are once again in a possibility of reversing the early onset dementia. And so that is again the awareness and the spreading the news about this new risk factor for this new form of dementia that is affecting now a much younger population than the one we are used to.
This is very important information. Dr. Pratico, this has been such a powerful conversation. And before we close, what's one thing that really you would like families to remember, those who are listening here today?
Yeah, there are a few key points I would like to really reiterate. I mean, we said a lot and we touched upon a lot of important aspects, but the concept that I would like to really stick with you as a caregiver, with you as a member family, is first of all, please. You are not alone. We are not alone. And I use the word we because this is a disease that affects everybody. So no one is alone in this. I want to use the word fight like people use for cancer. This is the battle of our century. This is something that we are working hard. I've been working hard for sure in my career. So no one is alone. You are not alone in this journey or in this fight. Another important concept is that dementia or Alzheimer's disease, if we want to be more specific, is not a death sentence. It's just a disease. It's such that there are today tools available to us as a caregiver, as a member of the family, that group that we can use and implement to really slow down the process. In some cases, we start to have also some very encouraging possibility of therapy. For the first time, we have now some therapy that is gonna attack a mechanism of disease. It's no more just a symptom, the dementia. So because we know more about the disease, nowadays we have started to have some tool that really can go after what is responsible of the death of the cell in my brain. So that should be the key point. Remember, it's a same person who has dementia or Alzheimer is the one has before. There's nothing different. It is an exciting moment. I just want to be clear with our audience. I am cautiously optimistic that we are on the right path, that really in the next couple of years, we're going to have very good tool, not just to make a diagnosis, because today the tool available for diagnosis and for testing are excellent. So that's another message. Today, it's an extra reason why we need to be proactive, because there are tools available to anybody to really have a clear and exact correct diagnosis. At the same time, we start to have available tools that can really make this journey much easier for the patient, first of all, but for the caregiver, for us or the family, and the one who really love this person. So these are the point. I hope they're clear that we are not alone and we need to be proactive because there are a lot of opportunity that can be followed to make this much easier.
Thank you, Dr. Praticò. I am actually excited about having additional sessions with you and conversations. But for the sake of time, I'm going to kind of wrap it up a little bit. But I want to say thank you again. Your expertise and insight are valuable to us here today on this session. And if you would kindly share your closing thoughts and also share your information on where people can go to learn more about your work and research.
Yes, absolutely. There are a lot of plenty of support online. One thinks that everybody should really use because it's an excellent source. Is the website of the Alzheimer Association. That is definitely one place where people can have a lot of information and as a general website. Of course, there are many other, such as the National Institute of Health or the National Institute on Aging. If people are interested in see all the work we have been doing in my lab, we have the Temple EDU website of the Alzheimer Center at Temple, obviously, and my website, the praticolab.org or drdomenicopratico.com, where you're going to find a lot of this information, some of the things we spoke today. I typically, once a week or every 2 weeks, I write a blog where I try to talk about topic again that are important for family, are important for the patient per se. And I have to to confess, most of the idea of those blogs come from you, come from people like you, from caregiver who email me with question, who email me with concern. And that for me, it's the most rewarding moment of my career because it means there is a conversation. This is an important bridge between science and family, science and patient. So it's important that our science get out of our lab, our silos, as they say, and really start to involve. Because ultimately, as I said, this is a fight. That's the way I see it. But it's a fight that will win for sure. But we'll win only if we work together as a doctor, as a researcher, as a family member, as a patient. Because the goal here is the motto of my lab. My goal is that memory should last a lifetime. And together we can make that. We will make that. I'm very optimistic. And with this, I just want to thank you again for giving me the opportunity to talk today about this very important topic. And I'd like to thank you also the audience for listening to our conversation. And I'm looking forward for the next one.
Just again, so that people can go and read some of your blogs. What is that website?
The website could be praticolab.org or drdomenicopratico.com. So these are two websites where they're really going to have a lot of information and they can even start a conversation with me if they like to.
Thank you. And to our listeners, thank you for joining us on this Caresify Spotlight series, part of Caresify Health Talks. For more caregiver resources, visit caresify.com. I'm Angel Bell, and I'll see you next time.